My name's Chad Miller. I'm a pulmonologist and the director of the Pulmonary Vascular Disease Program at Piedmont Healthcare. Pulmonary hypertension is an elevation in the pressure in the pulmonary arteries. These are the blood vessels that sit between the right side of the heart and the lungs. They carry unoxygenated blood or venous blood from the right side of the heart to the lungs to then get oxygenated. The elevation in pressure in those vessels can be caused by a number of things.
My name is Craig Patterson. I'm a pulmonary and critical care physician, and I'm a member of our advanced lung disease team that takes care of rare, unusual, complex, and orphan diseases within our specialty of pulmonary medicine. When we find high pressure in the lungs, we have to embark on a very specific and very thorough investigation of what is causing the pressures to be high. One set of conditions that might cause the pressures to be high, we specifically refer to as pulmonary arterial hypertension. When we say PAH, or pulmonary arterial hypertension, we're talking about a disease of the pulmonary blood vessels themselves that is causing that pressure to be high in those blood vessels, as opposed to a condition with, say, the heart having a problem, or a patient having emphysema or COPD, or another type of lung or respiratory disease that secondarily can cause the pressures to be high.
Hey man, how are you?
Typical symptoms of a patient with pulmonary hypertension most often always include shortness of breath, and that can be pretty much independent of what kind of pulmonary hypertension the patient has. In addition to shortness of breath, patients often experience lower extremity swelling, or what we call edema. Sometimes the symptoms are so severe the patient may experience episodes of passing out or be so short of breath they find it hard to do basic daily activities like getting dressed, taking a shower, or even making food.
You know, like I said, I just got to a point in pain where I almost lost it.
When we see individuals who have characteristic symptoms of pulmonary hypertension, then we very often will get to the point of recommending a diagnostic right-sided heart catheterization, which is the gold standard for not just estimating the pressures, but specifically to measure the pressures. And the right heart catheterization also gives us a lot of additional useful information about what may be causing those pressures to be high.
A catheter is placed in the vein, typically in the neck or the arm, sometimes in the groin. It is then guided down inside the heart and out into the pulmonary arteries themselves. Along the way, we measure pressure in the right atrium, the right ventricle, and the pulmonary artery. In addition, we can make some indirect measurements of what pressures are on the left side of the heart.
And based upon the patient's symptoms and their risk profile, we make a decision about what might be the best treatment approach for the patient in front of us.
And so this is the subcutaneous pump.
For about 1995, we didn't have a single medication to treat pulmonary arterial hypertension. And in 1995, a landmark drug called epoprostenol, which is marketed as either Flolan or Veletri these days, was introduced to the market and really created a paradigm shift or a complete revolution in the way that we treat this condition. Now, a situation where we have close to 20 different medications of 4 or 5 different drug classes, all of which may work in different ways, often complementary ways, to treat this underlying disease of pulmonary blood vessels that we call PAH. And then there's a new or novel drug class for the treatment of PAH that really was just approved for use in 2024. And there's only one medication in this class of TGF-beta signaling pathway modifiers. And the drug in this class that was approved in 2024 is sotatercept. This is a medication that holds promise, or a class of medications, I should say, that holds promise to potentially attack the disease from its very fundamental origins and roots, and in some cases may actually help reverse some of the changes that occur over a period of time when somebody has this disease. And it's really got the PAH world abuzz with excitement about what the future may hold as we develop additional drugs.
Pulmonary hypertension is basically high blood pressure of the lungs. Now there are a lot of options.
Our approach to patients with pulmonary arterial hypertension is first that of education and understanding. Within that lies a lot of power and frankly gives the patients a lot of hope.
We can get you out of the ICU to a regular floor.
So often they've been on a journey just to obtain a diagnosis and for someone to tell them what they actually have. Once we do that and they come to grips with the severity of the illness, we want not just for patients to not only survive and not be in the hospital, we want them back to life, back to work. Our aim in treating PAH here is more about the person than the outcome.
I may have as many as 20 different options, in my toolkit to be able to use to help someone first feel better. It would always be nice to help someone feel better, right? But more importantly, to help them potentially live longer. I'm just really excited about what the future holds, and it's a really distinct privilege to be able to care for this community of patients.
One of my favorite things is I demand stories of what they're doing now. I want to know. They so often ask, well, what can I do? My response, whatever you want, go and do it. It's not just that we improve their mortality or that we keep them out of the hospital, but it's another human being's opportunity to return to life. Being there for that is truly an honor.